Thank you very much for coming here. Welcome to this session about heterotopic valve implantation. We are very happy about the interest during the lunchtime. And we will try to have a very interactive session as well. So ask your question. You can stand up. You can send a question. I have just the question in front of me, and we will be happy to answer the question at any time. So we will start. We have a busy schedule, so I have a great panel of experts in heterotopic valve implantation, mainly from Spain, but also from Saudi Arabia, Sandoz, from the Netherlands, and a great panel of people. I don't want to present everybody. You will learn them and heard about their talk. But we have a nice Spanish representation. So we will have a live case as well, recorded live case. So I think quite a lot of interactivity. So Martin, you want to start with the presentation?
Absolutely. So first of all, thanks for coming to this session. So I will discuss the session objectives. So my disclosures are none for this session. So I think we all know that there's a large burden of TR in the population. And this comes from a large study that has been performed and with more than 900,000 of echoes. And we can see that it's really quite common to have a significant tricuspid regurgitation. So in this study, we can see that 7.1% of these patients have a significant tricuspid regurgitation. So it's a big issue, and we know that these patients can be asymptomatic for a very long time, but when they get symptomatic, they are hospitalized. They frequently have a poor quality of life and limited of options because surgery in the majority of these patients have a high surgical risk. So if we look what we want to do is intervene in these patients before they reach this point of no return. So before they end up in this stage where there is right heart failure is too and cannot be reversed anymore. So we want to treat these patients when they get symptoms and do something about it. We know that we have different options nowadays to treat these valves, but a nice option we nowadays have, and that's the only CE marked valve being available, is the TRICVALVE solution. And the nice thing about this solution is that you stay away from the valve or in the annulus itself. And we will discuss more about the valve, but this is a nitinol frame, like we know for a very nice, and what we can see is that the superior vena cava has this belly where we have a large skirt here with pericardium, bovine pericardium, to prevent PVL in these kind of patients. We can see the IVC stand over here, different sizes, accommodating to a large anatomy. We can do this, and this has a small PVL skirt, and also to prevent blockage of the venopathic vein. And what the idea behind the concept is, again, you're not treating the valve, but you're staying away from that, and you're treating the backflow in the body of these patients, which gives them the symptoms which make them feel worse. And what you can nicely see is in this animation, we can only see that the blood flow goes into the right heart, but doesn't go back. So an easy solution, and we will going to discuss more about this to help these patients. So what we're going to do is we're going to talk about patient selection and also the clinical values to consider to understand more about the concept and how we're going to implant this valve and learn about how this is going to improve the quality of life of our patients, and to understand the procedure of this procedure step by step and the clinical management of these patients. So, and for this we're going to go to a case by Fabian Prats, who's going to discuss one of the patients that's been treated with this technology.
Yeah, thank you very much, Martin. So you correct me. It's actually your patient I will present. It's a recorded case of a TRICVALVE case. You will see shortly. So it's a 63-year-old male with a massive symptomatic atrial regurgitation. The patient was operated before. He had right heart decompensation. You see also quite an advanced disease with some liver damage as well. Moderate post-capillary pulmonary hypertension, a significant wave, and the patient was previously treated or attempted with transcatheter edge-to-edge repair with a Pascal device. So a quite advanced patient with, I guess we will see the imaging in more detail, also dilatation on the right side, and a patient that was not suitable or not doable with transcatheter edge-to-edge repair. And on the right side of the slide, you see a a number of comorbidities that you have to take into consideration when selecting this patient. And altogether, you see an Euroscore of 5 and a TRI score of 14. You see the discrepancy between these two scores, the TRI score being a more adapted value for patients with tricuspid regurgitation. So that's the situation. I think Xavier will comment a little bit more on imaging, on the CT afterwards, but you see already the right ventricle is very dilated, much bigger than the left side, and you have severe tricuspid regurgitation. The imaging is also a little bit challenging here, at least transthoracic. And you will see here the transesophageal view, the transgastric view, which is extremely important with the coaptation gap measure, and you see here a huge coaptation gap of more than 15 millimeter. And then finally, the screening echo, very impressive, massive tricuspid regurgitation involving a big part of the coaptation. That's the medication of the patient. So you see that the patient was on very high dose of diuretics already. So he was not responding well to this. We have to say, with keeping hospitalized. He had thorazimide and spironolactone, and had also an heart failure medication that you can see here. Thank you very much.
So basically, I'm going to talk about the image analysis. I don't know if you can run the presentation.
Sure, I will do it.
You said Fabian here. And well, I'm gonna be there, like with a smart screen, it's fine, because basically I want just to highlight the key points, the key measurements of this procedure, and how we select one valve or the other. So I'm gonna be talking with this and showing in the smart screen, but I need some slides, because first of all, to know about the measurements, what you have to look, it's really important to know the valve. So basically, this is like the SVC, the valve that goes in the superior cava, where you can see that has, like this ball, like this shape. The valve, it's in the lower part, and here we have like that diameter. When we're talking about like a 25 or a 29, it means that it's, the lower part, the lower stent, and then we have like a 10 millimeters oversizing in this belly, in this part of the valve. This is the inferior. Actually, and I will show later what we're looking here. So basically, we have like different reference points, and those reference points are going to be crucial, in order to select and in order to place our catheters. So if we have like a regular patient where we have like the jugular vein here, so we have the subclavia, we have like the brachiocephalic, and then like we have the innominate, and then we will be something like this and something like this. This would be the right atrium, the SVC, the innominate. Okay, so usually what we recommend is just to put like a catheter, and that's what we're gonna see like in the CT, and this is gonna be like the distance between the confluence of the innominate here just to this point that it's like the mid right pulmonary artery. So this distance needs to be like over 35 millimeters. And that's, like just probably the most important, like measurement. So that, happens in, I would say, like 90% of the patients. But if not, if that doesn't happen and you have like a distance less than 35, you need to go a little bit higher. So in this case, you will need that this artery has, like a diameter over 40 millimeters. So this would be like just, I would say, the most important thing. So let's move to the image now. Focus your like vision there. Like in the slide where you can see a catheter in the innominate, you can see like the pigtail, in the brachiocephalic, and then you can see, nicely the superior vena cava. That would be the position. So we will like that belly, in that position. The belly will go over, like the pulmonary, artery, the right pulmonary artery, and then we'll have the rest, like of the valve like this. So this is going to be more or less, like the relationship with the other structures. So if we have the belly, remember that the skirt of the belly of the valve will go here. So that's that will allow just to have like a permeable, like innominate vein. So in the case of our patient, so just to select the valve, so, like with the CT, we measure on the left side like a diameter, derived from the perimeter of 25, more or less. Here you can see. And that's its measure at this level, no? You see the yellow line there. So from that, like measurement, we try to upsize a little bit, like around 5 millimeters. In that case, we're going to select the smallest one that it's the smallest one that we have, that it's a 25. If we would have like maybe a smaller one, we would go, but 25 it's going to be okay, because as you can see on the right side, we have like a distance with a confluence it's over 35, and then we have like a good distance to the right atrium. So the design of the inferior vena cava, it's completely different. In this case, we have like a stent, with like a dimension that you can see. The name, the size of the valve comes, for the superior, like the 31, 35, and 41. They're working on the 45. It's like the approval. And then what we try just to analyze here, it's like the confluence here. That would be the tricuspid valve. And here, would be the suprahepatic vein, and then the inferior vena cava. So in this case, and you can see there highlighted in green, that distance, it's really important, and usually it's the distance between, the junction with the right atrium and the suprahepatic vein, and needs to be more than 5 millimeters. Okay, that to provide a good stability. In the case that we're going to analyze here, it's also important to see, the angulation. Sometimes it's not that easy, it's not that nice like this. There's like an angulation, so it's something that we need to anticipate, like the movements of the valve. And in the case that we're going to analyze, again, like the diameter that we're measuring, that it's going to be at this level, more or less, it's 25. So again, we would like just to provide an oversizing around 3 to 8 millimeters. So in that case, we're going to end up with a TRICVALVE 31 that, again, like it's the smaller. So the length, in this case, that we have of this junction that's going to provide a lot of stability, it's 9 millimeters. So it seems that, it's going to be, like a good distance to provide like a stable implantation. So that's, like just a nice 3D picture of, like just the potential results. And now I would like just to ask, Dr. Ahmad, because I think that we're going to talk, about variability in the anatomy. So Dr. Ahmad has published a lot, in, like the variability, the anatomy of these patients. So if you want to just comment a little bit on that, please.
Yeah, after your beautiful draws, I cannot add much, but it's true that this therapy is quite simple. So the anatomy will not condition in the big majority of the patients the exclusion for the therapy, but when selecting the sizing and the correct positioning, there are some tips and tricks. First, the superior vena cava in some patients can be tapered and short, and sometimes it's not realistic. If we see by angio, it seems very short, but our patient who used to be healthy and young now is like this. So the vein is also bended like this and might look shorter, but when we analyze the center line by CT, we can have the true length of the vein, and in most patients, even if it looks short, it's longer, and we can do the procedure. Anyway, we need to tend to go higher in these patients, as you mentioned, yes, making attention not to occlude the innominate vein, and sometimes a peripheral vein can help us to see if we are occluding it or not. And regarding inferior vena cava, you saw here some images. I will help to interpret this. The green figures is the different shapes of the inferior vena cava, and it can be like a cylinder, it can be tapered to the top part or to the lower part. So if it's tapered to the upper part, and especially...
Sorry, can you show, please, the...
If it's tapered to the upper part, and especially if there is an angulation of more than 15 degrees, this might make it more challenging. We have been learning how to implant in these situations. One thing we can do is removing our stiff wire from the superior vena cava and keep it in the right atrium so that the valve will be oriented while we are deploying in the coaxiality with the inferior vena cava. These are, for me, the main tips and tricks.
Excellent. Thanks a lot. Excellent presentation and imaging analysis, Xavi. I think we can move forward now to the the actual case. So this is a recorded case from the Robert Bosch Hospital. So, Philip, if you can show us what you did and how.
Yes. Thank you, Martin. Fabien, thank you for inviting me today and for the recorded case. So we have this very nice lecture about valve sizing, and so it's absolutely easy to have this valve. These are pre-crimped and come of the correct size, and we had a very nice case presentation, patient presentation before, and so I can go on directly to this very nice procedure. We see here again the imaging of this very torrential tricuspid regurgitation. Due to this not possible edge-to-edge repair, we decided to go for TRICVALVE implantation.
So we have already prepared both groins. We have a ProGlide system in the right femoral vein because we will implant the valve from the right side. And now we can get to the next step and get a multi-purpose catheter into the right jugular vein. For the implantation, we will need a stiff wire in the right jugular vein in order to have enough height. So now we're in the right jugular vein.
It's very important to get
exchange the
this
J
height.
wire with an Lunderquist wire. Okay. So next we will insert a pigtail catheter into the brachiocephalic vein. So now we are in the right position with the pigtail catheter.
Perfect.
So we can now perform one angiography, which will help us to understand the correct position of the superior valve.
Yeah, there is the confluence.
And we can use this as a marker for our implantation later on.
Due to the CT scan, we go for an SBC 25.
Okay, I think we are ready to prepare the superior valve first.
Okay, preparing of the system is very, very easy. So the valve is pre-crimped, so it has only to be fluided, and that's everything. Okay, that should be fine. There's no air. No gap. No gap, no air. Okay, flush the wire port. Yes, okay. That's it. That's SBC 25. Okay. So this takes normally.
So now we are
3
ready
minutes.
to
That's very, very easy.
insert the valve very shortly. We will pre-dilate the groin axis with a 24 French dilator. Okay. And then we can insert the delivery catheter. Here we have a lot of space. Normally we have to be careful to be high enough with the nose cone of the delivery catheter in the jugular vein. And we can see here how the delivery catheter is already in the right position. So this should be the spot where we can start. Later on, there will be a belly of the superior valve, and that should be more or less in the confluence. We could do one further angio. Okay, so this looks fine. This is exactly the correct position. So now we will start very slowly releasing the valve by turning this knob clockwise. It is important to release the valve really slowly. For the superior valve, we mainly use the angios and the fluoroscopy as a marker, not so much the TE. For the inferior valve, the TE is very useful to see how much the valve protrudes into the right atrium. So the upper part of the valve is slowly starting to flare. So this still looks very good.
I think it's okay.
I have to pull a little bit since there's a tendency to move upwards.
At this time point, the valve is also fully retrievable if necessary. Now the belly begins to flare. Yeah.
We're a bit on the high side, so I should keep it under tension so that it doesn't move higher.
So for the panel,
So
so
now
the
I have to
SVC is
work a
very
bit
easy to
slower
implant. Yeah, no
to give the
problems with the
frame
SVC.
enough time to slowly expand.
Okay.
Okay, now you can see how the belly is already expanding. We would do another angio now. So this is basically the spot that we had intended for the belly of the upper valve. So we do a final angio before we pull back the pigtail catheter. Okay, so this looks nice, so we can actually pull back the catheter now and continue at that very spot. So for the final release, we have to work very slowly to give the valve enough time for the expansion and to avoid a jumping movement at the end. So now I will work a bit slower. There are 3 hooks, and we will wait for the first hook to be released. So it looks like, yeah, I think the first hook went off. So we'll just give it some time now before I continue. But everything is completely stable, so this looks fine. Okay. Looks like it's actually completely released. I think I can see all 3 hooks. I'll give it some time. But this looks like a very stable situation. Okay, now we are completely free.
Yeah, now it's free, absolutely.
Okay. So can we see the valve in the TE?
There is the frame and there is the valve. Perfect. Yeah, nice image. There is no paravalvular leakage.
Yeah, this looks actually quite nice already.
Yeah,
so it,
very nice
it looks
position.
like a complete sealing. And so this would be the situation where we can start preparing the inferior valve. So before we exchange the delivery catheter, we would quickly insert the pigtail catheter into the liver vein, since that will be our marker for the inferior implantation.
Yes.
Okay, so this is a
Nice landing zone.
good image, and we have enough space between the liver vein and the right atrium for the sealing of the valve. Before I retrieve the delivery catheter, I resheath it quickly. And then we can pull out the delivery catheter. We will leave the Lunderquist wire still in the superior cable vein. Later on, we will pull it down into the right atrium. Okay, so for the implantation of the inferior device, a very precise positioning is very important. And here we also use the TE to measure the protrusion into the right atrium. So this looks like a good position.
So I will stop here shortly. Do you have experience with TOE or pure with?
We did both of them. In the first beginning of the implantation, we were dependent more on the TEE, but in the last couple of cases, we went to the transthoracic with upfront screening. So the sonographer or the operator know exactly where to put the probe, and it was very helpful at the end.
Okay. So we love TE for especially for the IVC because the landing zone is very precise. Martin, what do you think?
Yeah, I agree. Of course, I love it in the procedure. So, but it's definitely possible to do it without, even without general anesthesia. Of course, that for some clinics makes it much easier to plan these kind of procedures. But at the end, I think superior vena cava is difficult. So frequently, it's high up, so it's not always visible. I think with the TE, but for the inferior, I think sometimes it can be definitely important to place it well on the TE guidance. In transthoracic, sometimes if image quality is good enough, okay, but patients are frequently with ascites on their back, so imaging is not always the most easiest thing. So I personally prefer, but also, of course, because I want to have some entertainment.
Yeah, and the thing is, we do it all on a general anesthesia. We had some not so good experience under spontaneous breathing, especially for the IVC, to be very, very stable at the correct position. So we do some breathing maneuvers normally. To reduce the tidal or the breathing volume to be very precise. So it may be helpful. And if you have this general anesthesia, you can also add TE, so as additional thing. Okay. And
well, the other thing is that, I mean, like those patients are like really sick in terms of, like general condition, but also in the kidneys. So, the more contrast you can save, I think that it's important. So that's my question. So you didn't put, I have two questions. You didn't put, like the catheter in the pulmonary artery, maybe because in that case, like it's not a problem, the contrast. And the other thing is that you give pure contrast, or you dilute like 50-30% in order to try just to...
No.
How much would be, in terms of general contrast, how much would be an intervention?
So we give pure contrast about 80 to 100 milliliters. Yeah, it's not so much. Yeah.
It's not so much.
It's okay. Yeah, in cases where renal function, we try to reduce it. Yeah, but normally I think 100 milliliters. I think that's okay. Yeah, and that's feasible. Yeah.
Xavi, do you have the idea, if you do it under general anesthesia with TE, that you can use less contrast? That maybe for especially the patient.
Definitely, you can use like a 30% contrast, and then if you're using for the inferior vena cava for sure, you don't need to inject that much because you have the pigtail as a reference. And in the superior, I mean, with the T, you don't see too much while you are implanting, but I mean, a good marker can be, like a catheter in the right pulmonary artery. So you know that the belly needs to be always up. Yes. And then you also have, a catheter in the innominate. Yeah. So in theory, you can even push the intervention to, I would say, like not zero, but, like a minimal contrast amount, And I think that, like those patients, at least in my experience, the ones that come to the lab, are very sick in terms of kidney. So that's, like a plus, definitely a plus. Yeah.
Yeah. Another thing is we do it sometimes in failed TEER procedures. Yeah. And so the right heart catheter maybe not so easy. Yeah. And sometimes you have this, as you see in the example, you have this floppy matrix or triclips. Yeah.
But you don't need a swan. You can put like a 5 French JR.
Yeah.
So
that's okay. Yeah. Okay, I will go on with the IVC.
I think we can also see at least the delivery catheter very nicely in the TE. And I would now start with the very slow release of the valve. So this is the situation where general anesthesia is of real help, since a deep breathing of the patient would be really difficult in positioning the valve, and a controlled respiration makes it much easier. So I can already feel that there is a slight pull towards the right atrium, so I have to pull it a bit down, give a bit of tension. So slowly we can see that the upper part of the frame is starting to flare. Maybe we could do another angio here. Okay, I think we are still in a good position. And very soon we will start using the TE images to understand if we have the correct height.
Yeah. We are at the edge. We are exactly at the entrance of the right atrium. Lisa, what do you think?
Yeah, maybe we are looking into the right atrium just a little. Just a few centimeters now, millimeters.
Yeah. So this would be an acceptable protrusion into the right atrium. We aim at about 0.5 to 1 centimeter. So this would also be the situation where we could pull back the wire a little bit. It's still in the superior caval vein, and the superior and inferior caval vein are not in the same line. So keeping the wire there would affect the position of the valve right now. It's always a bit challenging to really measure it exactly. So this would be
a little bit too much, I think. Yeah.
So this looks like a nice position. In general, we have the feeling that this is the right position. We shouldn't be lower. It's on the lower side already. And we just continue.
The last measurement, about 9 millimeters.
Expanding furthermore.
That's at the max 0.8. I think that's okay. Yeah.
So I have to keep a bit of tension here so that it doesn't move into the right atrium.
Now it has the tendency to go a little bit more up. Lisa, has it moved a little bit to the right atrium? No, it's
no,
the same.
I don't think so.
It's
but
the same
I can
position
do another
here.
measurement. No, we are still
Okay,
around
so this
9 millimeters.
would be a nice value. So I'll continue. If we can keep this position, that would work well.
It's about 1 centimeter.
Mm-hmm. And here the breathing
So
maneuver
now I
is
have
very
to
helpful to be
a
very
bit
precise.
slower.
And maybe it's
Releasing
important for the audience
inferior
also,
valve
if they haven't performed this procedure, that the tendency of the valve is moving up to the right atrium. So you have to, until the end of the procedure, you have to keep a little bit of tension down. No? So,
when you say breathing maneuver, you stop the respiration?
Sometimes stopping or reduce to 250 milliliters, so that we have only a very, very low breathing for a few minutes. That's no problem normally. Yeah.
And Philippe, before you go to the implantation, there is a question from the audience regarding the risk of device embolization. So we see you are adapting a lot. There is a lot of, you're very cautious in having a good position. And the question alludes in particular to the absence of calcium, but you don't rely so much on calcium. You don't need that. It's oversizing of the...
Yes, that's pure nitinol. We don't need calcium. I don't know if there is calcium in the vena cava.
Oh, no. It's really based on oversizing.
That's important to understand. So it's mainly oversizing. And but regarding embolization.
Oh, we had no experience with embolization. I think the SVC is very stable, very, very safe. So the IVC, you have to be very precise because the landing zone is very tiny, and I think there is a little risk of embolization. But if you're precise and you can also retrieve the valve, if you see that it's go more up, so I think the risk is very, very low for embolization.
Very safe procedure.
I think it's well noted. It has a tendency to go up. So, and the nice thing is, even you can deploy the valve almost completely and still go back. So it's quite still far you can go, and for 90% you can still retrieve it completely. completely. So if it goes down, it goes up in the right atrium, you can retrieve it back and completely start over again. I think that's the nice thing about the valve.
And also, it's important to remember that the skirt is 20 millimeters for the smaller valves, and if you are like in this position very tight, adjust to the right atrium. When you release the valve, if there is a slight movement towards the right atrium, then you still have like 20 millimeters or 10 millimeters more of the skirt. So you cannot you won't have a paravalvular leak because there is the skirt outside. Yeah.
Excellent.
I go on with the end
you
of
have to
the
do very carefully
procedure, 2-3 minutes, and then
so that the valve doesn't jump upwards.
We want to see the
Okay,
implantation.
this still looks stable and good. So we could remove the pigtail catheter now and continue releasing the valve under TE control.
Nice image. Okay, yeah, that's the same position. Okay.
Okay, so now we are not far away from probably releasing the first hook. So now I have to be very slow and careful.
It's very controlled.
You can also orientate on the thoracic sutures.
What happens if you
So
forget?
at this point,
if
you
you forget
really
the
have to
pigtail?
take your time.
I don't know. I don't think that there is
I
any
move it
problem.
with a thermal
Okay,
wire.
so the first hook, the second also just went off.
Okay, it's 0.8. It's perfect.
And so I will just wait a moment to give the valve some time.
One important point
but
here is
this
that you can
looks
see
very stable
that
at
the
this
tip is
point.
moving because they have no tension at all on the wire. That is quite important because if you have a lot of tension on the wire and the wire is in the SBC,
for the
it can
nitinol
try to
frame
jump.
to
But that is perfect. I mean, very slow deployment
Super slow.
and no tension at all on the wire.
You mean the nose cone movement?
Yeah.
That's what you look for. Yeah. And you see it
And
very
now I
nicely.
will really very slowly continue turning the wheel here.
Moment we have a good sealing.
Okay, so the
That's
third
done.
hook went off too. So I'll wait a moment, but the valve should be completely free already, and it seems to be also completely stable, which is a very good sign.
Yeah, also in the echo, I see it stable.
Until the end.
All right, so this looks really nice.
So there are a lot of questions
I
from the
think
audience, a
we're-
lot of interest on,
completely free.
for example, how many times you can resheath the valve. You know that, Xavier? How much is
Well, I mean, like fully or just like partially, because it depends. No, in general, like they say that like you can recapture up to 80%. Like practically you can do more, but the upper part. So if you don't open completely, I mean, you can just
play.
recapture
There is no
quite
limit.
Yeah. Not so many, but I mean, it's like I don't know if there
I
is
think
like a formal, but it's just part of the game, just to open. So here, just like a small comment, and like just in line with what Ignacio said, that probably the worst enemy, just to have embolization, because here the risk is that the valve goes into the right atrium. It's like a tapered. Like cava. In this case, we had like a nice cava that was like straight, and when you have like this anatomy, like you can be quite, like just happy. Also, you need to play a little bit with the oversizing based on that. So if you have like a taper that it's narrow, like in the inferior part, you're not gonna go like super oversized, because then at the end, when you release, it can jump in. So these are like things that like of course like the company helps a lot and gives like very good advice, but like they play a significant role.
So we had one case with a little movement, after deployment, but the sealing was perfect, and so everything was fine. So a little movement is okay. So I will go to the very end of the procedure. You see here we have a perfect sealing. We have no residual tricuspid regurgitation. My boss always uses a ProGlide system. Yeah, I use only the set suture. I think we have no difference. We have bleeding is not a thing in these procedures. Yeah, and we also don't need any transgastric view. Yeah, that's also in this tricuspid regurgitation patient or right heart congested patient. So you see here, perfect sealing. We have no residual tricuspid regurgitation, and then I go for at least for the measurement for the and you see here on the backflow we have this reduction of the V wave afterwards, and so this was 2 months ago. Patient is very fine, no edema at the moment, because he has a good RV function, he has a good RV-PA coupling, and so I think this is a perfect patient for TRICVALVE, and then I'm at the end with the procedure.
Congratulations. Martin, there is another attempt to replace you on echo.
Oh, really?
From the room.
Oh.
And the suggestion would be IVUS.
IVUS, yeah.
Why not?
Yeah. Why not? Why not? Yeah. We didn't use it yet, of course, but they will be in a fight with me, putting me out of the room. So, yeah, why not? Why not?
Maybe a big structure. You know, this IVC, SVC, they are quite big. I'm not sure you can see it with IVUS. Dama, do you have experience?
Actually, there is some experience from the group in Cleveland Clinic for zero contrast use in patients with
use IVUS,
failure, and they have very nice images and very nice results. I have not.
Oh, really? Yes. So you see,
so at the end, I'm not needed anymore. Now, so thanks a lot for the case, Philip. I think it nicely showed, because even it was a complete case, and it nicely showed how easy and how straightforward the case is. It nicely is. It goes fast. The pre-crimp valve already helps you to really save a lot of time. So the whole case done is easily in half an hour or something like that. Normally it goes quite fast. So I think very nice case. So I think for now, if you have any questions from the audience at the moment, Fabian?
Yeah, the people are still asking a lot, and thank you for the interest and the curiosity. But there is a question regarding the indication, maybe for you, Ignacio. Who are the patient you consider for this procedure, and maybe in comparison to orthotopic? You know, but what are these patients different?
Yeah. That is an excellent question, because for me this is the key point for this procedure, because we have just seen how easy it is to implant the valve. So I really feel that the key point for TRICVALVE is the selection of the patient from the clinical point of view. So the ideal patient for me should be something like what we have there. I mean, a patient should be really symptomatic, because the main goal of this procedure is to relieve symptoms. We can discuss about RV remodeling, RV function, these kind of things, but the main goal is to relieve symptoms. Second, the patient should have, of course, massive to torrential TR, but with high big wave in the superior or the inferior cava. If you don't have high big wave in the inferior and superior cava, it's not going to work. And finally, it's quite important to have patients that don't have RV dysfunction, severe RV dysfunction, or severe pulmonary hypertension. Because if you have severe pulmonary hypertension, or you have a very depressed RV function, you can collapse the RV when you deploy the valve. So the patient that Philip had just presented us is the perfect candidate. Symptomatic RV, the TAPSE was around 14, not really high pulmonary pressure. So that is the patient I will consider for that. And regarding your initial question, I will consider initially repair, and if you cannot do repair, you can go for this.
So that means the patients are more advanced than the one you use or you select for repair. Is that the case, David? That's more advanced population?
Well, I think that in a sense, you know, like that's like a very like a rescue tool. I mean, you can just treat all kinds of patients. It's true that, you know, like from the surgery, you know, that maybe repair it's better than substitution. But at the end, you know, like it's a very useful tool. For example, and that's going to happen more and more. If you have like a edge-to-edge repair that, you know, like you have attachment and you don't get a good result, you cannot put a valve there, you know, because you have already the clips there. So then it's a very good tool, you know, for failed repairs that we're gonna have, as I said, like more and more. It's also very good for, like just abandon or like functioning leads, leads of the pacemaker. So, like that valve, that system can be implanted without any problem. So, there's a lot of room, and I think that in the future, since we're treating more patients, we're gonna have like room for all the techniques. Yeah.
Maybe, Luis, you can tell us something about pacemaker. You mentioned this, Xavi. You can implant without any problem. Which pacemaker lead are doable? One, two?
Maybe you... No, you just you answer, yeah.
Yes, we have treated several patients with a pacemaker. I think there is no problem for this procedure. Of course, we usually check and review the pacemaker before the procedure. We check all the parameters of the pacemaker, and then we go after the procedure. We review it again, and we haven't seen in probably more than 10 cases that we have done with a previous pacemaker. We haven't seen any changes in the parameters of the pacemaker. So it's another option, another advantages of this treatment, that when you have to repair with a clip and a previous pacemaker is problematic, and sometimes a lot of times it's not possible. So with this procedure, we didn't have any problem, and even with more than two leads in the superior vena cava.
So we see the one of this procedure here. So basically, you would jail the lead, 1, 2, or more. Some patients, we have a lot of trouble actually with patients with several leads. Yeah. Like three leads. That's a situation where you are really limited with the device we have currently. So that's also a nice indication for this. So you jail the lead, and as you mentioned, you don't have any negative effect on the pacemaker. I'm not aware of any case of change in any of the parameters of the pacemaker.
Good. Yeah. So I think, and Ignacio already mentioned, so it's about very symptomatic patients. That's the crucial part of selecting these patients. So maybe Sundus, can you tell us a little bit about the outcomes of these patients? How do they perform? How will the?
So usually, from our experience and also from the data that we have like tremendously next day, within 24 hours, good response of subsequently and regress in their lower lymphedema, and we have seen this even in our series of patients. And then within the course of 1 to 2 months, we see even the ascites to go down. And for patients who've been having frequent ascitic tabbing and hospitalization, also it goes down within the upcoming 6 months after the procedure, which is a good thing for them from the clinical perspective. And nevertheless, of course, the quality of life has been tremendously impacted on them. And this is what, the goal is, like, to make their life go better. From the echo perspective, I don't know, like from you, we have noticed for people, like we were talking about the indications coming early, late, very complex anatomy. We noticed that for the patients who are like not very late, not very advanced stages, once we put both of the valves and we put the probe, like we were talking on the table, the TR may get less. And we should expect that long the run, after a few months at least, for the RA to adapt. But we have noticed for people who are coming, not late stage or actually early stage, their TR is going down. Even the TR Doppler signal is becoming narrower rather than the wide, what we know from the TR. So I don't know, what's your take from the echo perspective on that?
I think now maybe Ignacio can tell us a little bit about that, because what I frequently hear is that you're not treating the valve itself, the tricuspid regurgitation remains, but we're treating a little bit different stage. So what will happen on the right side of the heart? Can you tell us about that?
Yeah, so I think it's legit to have some concern, because when we treated the first patients that were especially advanced patients in heart failure, we have an acute increase in the V wave in the right atrium. So which is the impact of that in the right chambers? Initially, when we have the echo core lab at 3 months, there were some doubts if the right ventricle might dilate. But at 6-month follow-up, we have the CT for these advanced patients and the echo as well. And we saw a remodeling of the right ventricle, not the atrium. The atrium remained the same, but the ventricle size decreased. So which is the mechanism of that? I'm not sure. I think there is because of a decrease in pulmonary hypertension in these patients. But I know that there are positive consequences of that. First of all, the dynamic of the right heart can improve. Second, there was a trend to a decrease in the tricuspid ring. So maybe there might be some decrease at longer term in tricuspid regurgitation, or if there is not, maybe we could treat these patients with therapies like TER that currently we cannot treat if they remain symptomatic, I mean. So this is very interesting. We need to explore a longer term. This is only 6 months, but there is a positive remodeling.
I think what you also, and I think you mentioned it well, is the enormous diuresis after this procedure. It's what you see with a lot of tricuspid intervention, but also this immediately the day after the procedure, you really have to reduce frequently the amount of diuretics because...
And actually this decrease was despite a significant decrease in the dose of diuretics, a very important decrease at 6 months.
Sure.
Yeah. Interesting. So maybe finally, Xavi, can you tell us a little bit about the management of these patients? How do you pre-treat these patients? Do you need anything, anticoagulation around these procedures? Of course, a lot of patients already have atrial fibrillation. So how do you manage this around this procedure?
Well, maybe before it's like what Ignacio said. I mean, maybe for those patients with RV dysfunctions, like mild or moderate, you can precondition it a little bit, like with some vitamin or levosimendan. But then, like the pre-treatment, I mean, for that technique, like for H2H, it's really important because you might modify the coaptation gap. For this technique, it's not that important, in terms of the diuretics. So after, we usually recommend anticoagulation. Okay, so either those are patients with atrial fibrillation, most of them. So the indication of anticoagulation it's already there. So it's like either with antagonists of vitamin K if they have like a mechanical valve or whatever, or like direct oral anticoagulant. So that's allowed. Okay, and in terms of diuretic, I mean you have to go careful because as Ignacio said, like those patients are going to lose a lot of weight. So you have just to manage closely those patients.
Okay, good. So, maybe one short question, maybe before we go to a question from the audience. Philip, the learning curve, because it seems like we discussed already, like an easy procedure to perform. So straightforward, easy going. But is it the case? What do you think? Yes, is there a learning curve?
Absolutely, absolutely. I think the key features is that it is really very easy to implant. Yeah. We need some imaging, some TOE imaging, or we love it, but it's not absolutely mandatory. It's nothing comparable with edge-to-edge devices or edge-to-edge repair. I think it's absolutely easy, and the other key feature is that we have so less screen failures from a procedural side. Yeah, so. Nearly every patient gets some size of the valve, so this is very important. And so the valve is pre-crimped. It's really easy. Yeah.
But then just like a punctualization, because you can see here in the last line, that you can have like a neuropathic pain, and this is important, because maybe you have heard about that. So it's like a mechanism that it's related to the oversizing, not of the superior, because you have like right shoulder pain. You might think that it's like the superior. It's not. It's like usually the inferior. So we have like a colleague, Dr. Omar Abdul-Jawad, that it has like published like a very nice paper that it's the oversizing, the excessive oversizing of the inferior vena cava, the one that goes or can be related with this kind of symptom, that it's a neuropathic pain that usually, if you treat it, with gabapentin, usually goes away in 24 and 48 hours. So it's like something that is transitory. So like you have to explain the patient that it might happen, but then it will go away. Yeah. That's important.
Patient and the physicians.
Yeah.
Do you treat the patients, because our routine practice is to give gabapentin 1 week for the procedure. I don't know if you do it because it takes time a little bit to.
So yeah. Now we're like using the anatomy and the imaging just to know like if the oversizing is excessive. You need just a lot of oversizing. So we do that.
So maybe we have a little bit of time left. Maybe some questions from the audience.
Yeah, we have a lot of questions. Yeah, so short response, guys. So if the patient, that's something, Luis, we did not address actually, but if the patient did not have a pacemaker but require one afterwards, how do you do? Is it possible to implant through all the system?
Yes, well, of course you will have to check if the stent of the valve is jailing also the innominate, if you want to go from the left side. if you want to go from the right side, probably the subclavian is not covered by a stent, and you can try to go through the. I mean, it's not a problem. We have performed several right heart caths after the trick valve implantation to measure the pressure, so you can go through, but it will go through the leaflets, of course.
And so the leadless pacemaker, that's possible? Have you seen that?
We have had this experience. We have done many procedures through the valves, transeptal procedures, left atrial appendage, and not issues. I will wait for 2 or 3 months if possible for other procedures, so that is already endothelialized. But for pacemaker,
may I add, it's also absolutely easy to close a PFO with a system. Sometimes you have this iatrogenic PFO after edge to edge on the mitral side, and so with the bicameral valve you will get right-left shunt, and then but it's absolutely easy to do it directly after the procedure.
And then there is an interesting question regarding the increase of the pressure in the coronary sinus. Any negative effect of this that are known on the coronary circulation? Who want to answer this? It's a difficult one.
I want to answer because it's like the 4th time I hear this question. There is an acute increase in pressure, but this is just when you implant the valve. Then the patient will compensate, the heart failure will improve, and pressure will go down. So it will be better than before the procedure, and also in the coronary sinus.
And then there are also concerns regarding the liver circulation. And that's an interesting point, because actually you have the skirt, but the stent is still open at the height of the liver. So is the liver circulation still under pressure?
Not at all. I mean,
that's the question.
The frame is open. I mean, the stent is open. You have only the skirt in the upper part, so there is no problem with that. I mean, even in sometimes, one of the limitations from the anatomical point of view is the distance between the right atrium and the suprahepatic veins. But sometimes you can play with the distance because sometimes the suprahepatic vein is quite big. So even you can close half of the suprahepatic vein and there's not going to be problems with the flow.
Yeah, but I think the point is that you are completely closing the backflow from the right atrium with a skirt, but the liver circulation is still open for backflow in the vena cava inferior. So you don't have any backflow in the liver anymore.
I mean,
so
it should improve.
Yeah,
the liver
even improve. Yeah, absolutely.
Improve because you don't have the backflow pressure.
Yeah. Yeah. So you have like the valve, the functioning valve in between the right atrium and the suprahepatic vein. So the skirt is just to avoid paravalvular leak. The problem is that if like the valve goes into the right atrium, then that skirt it's all inside. So then you have backflow to the. So that's a problem. But in theory, like the suprahepatic vein is protected.
Yeah. And can you perform a tricuspid procedure through the system? Has this been done already? Because actually, if you reduce the volume status of the patient, the anatomy may respond as well, and the patient could be amenable then in a second step to something modifying the valve. Whoever or Saunders.
We are targeting for symptomatic improvement. If TRICVALVE was successful, normally we already have the symptomatic improvement. So should not be necessary. But we have evaluated one case, and if the patient deteriorates, this would be feasible because now the gap is smaller. We have a 2 or 3 millimeters reduction in the diameter on the tricuspid annulus. If ever the patient, again, is symptomatic, we might consider it.
And so, in terms of follow-up, are you doing CT scan, for example, in this patient to look at the evolution of the anatomy to control them, or you just do echo?
Follow them clinically, basically. And with this new area, sometimes telemetry medicine. We've been calling them and asking them how are they doing. So, and just to confirm with everything, to do an imaging, we have a sub-registry in our hospital with all right-sided intervention. We're doing MRI for them to check the pre and post response of the right side. So they are included in this, and I think they're just around the corner to do their MRI. I don't know if MRI pre-procedural planning, and also I think now there's like a protocol been under process to use the MRI to avoid contrast in the planning for the sizing for the device also, if I'm not correct.
Good save. So I think we're out of time, unfortunately. There probably may be some more questions, so maybe after the session you can come up and ask us. So for the take-home messages, I would say I think we nicely saw that it's an easy and a fast procedure. So the learning curve we discussed, it's relatively short. If you have some experience, I think, with TAVI or other valves being implanted, this goes really fast. So skin to skin really is around 45 minutes, something like that. And if you do the screening right, and I think that there's a high procedural success, but also a lot of patients are accepted for this therapy. So the valve is already pre-crimped. So it's nice, it saves time, there's less manipulation and less contamination risk. And we can see that the valve is recapturable for quite a long range, so it's easy to recapture and reposition the valve, and especially, as we said, for the IVC, if it has the tendency to go up, we can reposition it again. So it doesn't disturb with right side structures, so no interference with the tricuspid valve or the annulus. You might not want to use general anesthesia, put me out of work. And at the end, I think we can see it very well on fluoroscopy, and it's also suitable in pacemaker patients. So I think it's a nice option, and I think we nicely saw that these patients benefit a lot symptomatic-wise, and that's the first treatment target, I would say. I would like to thank the audience for being here, the panelists for being here. Nice lecture, and thank you, and I wish you a very nice congress.